Welcome back to the GLP-1 Science series. In the last video, we gave you the big picture, all the organ systems that GLP-1 medications work on. Today, we're going to deep dive on the one that matters to you the most, your heart. Because cardiovascular data behind these drugs is not just good, it's some of the strongest evidence in modern medicine. And most people, including many patients taking these medications right now, have no idea that it exists. The question that started it all. For years, the big question was simple. Do GLP-1 medications actually prevent heart attacks and strokes, or do they just improve numbers on a lab report? To answer that, researchers ran some of the largest and most rigorous clinical trials ever conducted in medicine. These are called cardiovascular outcome trials, and they're the gold standard. Tens of thousands of patients, years of follow-up, real outcomes, not just cholesterol numbers, but actual heart attacks, actual strokes, and actual deaths. Let's walk through the landmark trials one by one. The LEADER trial was the first to prove cardiovascular superiority for a GLP-1 medication. It enrolled over 9,300 patients with type 2 diabetes and high cardiovascular risk and randomized them to Liraglutide or placebo. After nearly 4 years of follow-up, Liraglutide reduced the composite of cardiovascular death, heart attack, and stroke by 13%. But here's what really turned heads. All-cause mortality, death from any cause, dropped by 15%. That's not just preventing events, that's keeping people alive longer. Next came SUSTAIN 6, which tested injectable semaglutide in about 3,300 patients with type 2 diabetes and established cardiovascular or kidney disease. The result was a striking 26% reduction in major adverse cardiovascular events. The benefit was driven largely by a 39% reduction in non-fatal stroke. This was the trial that put semaglutide on the cardiovascular map. Now here's where the story gets really interesting. Every trial up to this point had been in patients with type 2 diabetes. The question was, does the heart protection depend on blood sugar improvement, or is something else going on? The SELECT trial answered that question definitively. It enrolled over 17,600 patients with obesity and established cardiovascular disease, but crucially, none of them had diabetes. Semaglutide at the 2.4 milligram dose reduced the composite of cardiovascular death, heart attack, and stroke by 20%. And a follow-up analysis showed that the cardiovascular benefit was consistent regardless of baseline hemoglobin A1C and regardless of whether hemoglobin A1C changed during the trial or not. That means the heart protection is not just a side effect of better blood sugar. Something deeper is happening. The most recent major trial is SOUL, which targeted oral semaglutide, a daily pill, not an injection, in over 9,600 patients with type 2 diabetes and established cardiovascular or kidney disease. Over a mean follow-up of nearly 4 years, oral semaglutide reduced major adverse cardiovascular events by 14%. The benefit was driven primarily by a 26% reduction in non-fatal heart attacks. This trial confirmed that the cardiovascular protection of GLP-1 medications extends to the oral formulation as well. When you pool all the major trials together, 10 trials, over 71,000 patients, the numbers are remarkably consistent. GLP-1 receptor agonists reduce major cardiovascular events by 14%, heart failure hospitalizations by 14%, and all-cause mortality by 12%. These are not marginal effects. These are clinically meaningful reductions in events that kill people. This is where the science gets fascinating, because GLP-1s do not protect the heart through just one mechanism. They work through at least 6 different pathways simultaneously. First of all, blood pressure. GLP-1s lower systolic blood pressure by about 2 to 5 millimeters of mercury. That may sound modest, but at a population level, even a small blood pressure reduction translates into meaningful reductions in heart attacks and strokes. The blood pressure effect comes partly from weight loss, but also from direct mechanisms: improved sodium handling by the kidneys and better blood vessel function. Second, blood vessels function. GLP-1 receptors are present on the cells lining your blood vessels, the endothelium. When activated, they increase nitric oxide production, which causes blood vessels to relax and dilate. Research in animal models has shown that this endothelial GLP-1 receptor is actually required for the cardiovascular protection. When it's knocked out, the benefits disappear. Third, inflammation. This may be the most important mechanism of all. GLP-1 medications significantly reduce C-reactive protein, a key marker of systemic inflammation, by roughly 20 to 40%. They also reduce TNF-alpha and interleukin-6. A 2026 study in the European Heart Journal showed that GLP-1 medications reduce atherosclerotic progression and inflammatory biomarkers even in subjects without diabetes or obesity. And that reduction in inflammatory markers partly mediated the reduction in cardiovascular events. Fourth, cholesterol and lipids. GLP-1 medications modestly lower LDL cholesterol and triglycerides. They also reduce the production of chylomicrons, the fat particles your body makes after eating, and VLDL particles from the liver. Cleaner blood lipids means less raw materials for plaque buildup. Fifth, plaque stabilization. Inside your arteries, GLP-1 medications reduce the activity of matrix metalloproteinases, enzymes that can digest the fibrous cap holding a plaque together. A ruptured plaque is what causes most heart attacks. By stabilizing plaques, GLP-1 medications may prevent the acute events that are the most dangerous. And sixth, direct effects on immune cells. GLP-1 medications reduce the infiltration of inflammatory immune cells into artery walls. They decrease macrophage content within plaques and suppress the secretion of inflammatory cytokines from foam cells. This calms the inflammatory fire inside the vessel wall that drives atherosclerosis forward. Beyond atherosclerotic disease, GLP-1 medications are showing remarkable benefits in heart failure, specifically heart failure with preserved ejection fraction, or HFpEF. This is the type of heart failure most closely associated with obesity, and it has historically been very difficult to treat. In the STEP HFpEF trials, Semaglutide dramatically improved symptoms, quality of life, and exercise capacity in patients with the heart failure and obesity. In the SUMMIT trial, Tirzepatide reduced the composite cardiovascular death or worsening heart failure by 38%. A pooled analysis of these trials confirmed that GLP-1 and related medications represent a genuinely new treatment option for this challenging condition. GLP-1s are not heart drugs by accident. They are protecting the cardiovascular system through multiple simultaneous mechanisms: lowering blood pressure, improving blood vessel function, reducing inflammation, improving lipids, stabilizing plaques, and calming immune activity within arterial walls. The clinical evidence from LEADER to SUSTAIN-6 to SELECT to SOUL is deep, consistent, and growing. If you're on the GLP-1 medication, your heart is getting protection that goes far beyond weight loss. And that is something worth knowing. In the next video, we will cover GLP-1 medications and the kidneys, including the landmark FLOW trial. Make sure you're subscribed so you don't miss it. Real science, real surgery, real results.